Welcome to the deep dive. Today, our mission is to really get into Chapter 52 of Porth's Essentials of Pathophysiology. That's the one on disorders of skin integrity and function.
Right.
We're aiming to, distill it all down, the key concepts, the mechanisms, so you can grasp the essentials quickly.
And the skin is, well, it's pretty unique in patho, isn't it? Because it's right there. You can see the signs of trouble immediately.
Yeah, visible distress.
It's like the body's frontline warning system. It's where everything from sunlight and bugs to internal physiology all meet. Understanding skin issues really means understanding how the body defends itself. Or sometimes fails to.
A warning system, exactly.
Ah.
But you need the code book to read those warnings.
Mm-hmm.
So let's start right there with the language, the terms we use.
Okay.
Our sources make a pretty clear distinction between a rash and a lesion. What's the key difference there?
That's fundamental. A rash, well, think of it as a more temporary, often widespread eruption on the skin. A lesion, though, that points to a specific pathologic change, a loss of normal structure or function. It's more localized, usually.
And lesions aren't all the same either, right? There's primary versus secondary.
Exactly. Primary lesions are the ones that pop up first on previously normal skin. Secondary lesions are what happens after that initial lesion.
Like if it gets infected or scratched.
Precisely. They result from the primary lesion changing over time, maybe crusting over, or like you said, getting scratched.
Scratching. That brings up pruritus itching. Seems simple, but it's a huge symptom in dermatology.
Oh, absolutely. It's incredibly common. And that simple act of scratching can cause real problems in excoriations, basically tearing the skin open.
Which then opens the door for secondary infections.
Right. And this discussion about damage ties into lesion depth. You mentioned primary and secondary, but how deep the lesion goes is also critical, like comparing a fissure and an ulcer.
Yeah, let's describe those. How would you paint a picture of, say, an ulcer versus a fissure for someone just listening?
Okay, so a fissure is like a crack. Think of really chapped lips or athlete's foot tinea pedis. It's a linear split, might go down to the dermis. It's painful, but usually it can heal.
Annoying, but maybe not catastrophic.
Right. An ulcer, though, that's a different beast. Here, you've lost tissue past the epidermis, often deep into the dermis or even further.
So deeper tissue loss.
Definitely. You'll often see necrotic tissue, maybe bleeding, it will scar. And importantly, an ulcer often signals a bigger underlying issue, like poor circulation and a stasis ulcer, or constant pressure causing a pressure ulcer. The depth tells a story.
That makes sense. And assessing these can be tricky, especially as the source notes in dark skin.
Yes, that's a crucial point. Changes might show up more as shifts in pigmentation, hypopigmentation, like lighter patches, or hyperpigmentation, darker patches. This can make some disorders harder to spot or evaluate accurately.
Okay, so we have the basic language down. Let's move on to the invaders. Section 2, infectious disorders. Let's start with fungi.
Fungal infections or mycoses, they seem simple, but they're well adapted.
How do they actually cause damage, like with ringworm or tinea?
Well, most of these superficial fungi, the dermatophytes, they live on dead keratinized cells, your outermost skin layer, hair, nails.
Okay.
Their trick is they secrete enzymes that literally digest keratin. That's why you see the scaling, or why nails might crumble or hair breaks off. They're essentially eating the keratin.
So the general term is dermatophytoses.
Yes, or tinea or ringworm. We just name them based on where they are. Tinea corporis on the body, tinea capitis on the head, tinea pedis feet, tinea unguium nails, tinea cruris, the groin.
But the basic mechanism is that keratin digestion.
Largely, yes. The exception mentioned is tinea versicolor. That one doesn't produce the same enzyme, causes more pigmentation changes.
Got it. Okay. Moving from fungi to bacteria. The text mentions impetigo, which is superficial, but then there's cellulitis. Why is that one such a concern?
Cellulitis. Key things are depth and spread. It's not just on the surface. It's an acute inflammation deep in the subcutaneous tissues, sometimes even deeper.
And it spreads.
Rapidly. It's often caused by bacteria like Staphylococcus aureus or sometimes Pseudomonas. Clinically, you're looking for spreading heat, redness, pain, swelling. The real worry is it becoming systemic, leading to sepsis if you don't treat it quickly.
So bacteria spread outwards and deep. Viruses, though, they work differently.
Right.
Let's talk about herpes zoster shingles. How does that VZV virus create such a specific localized pattern?
That's the fascinating part about viruses like varicella zoster virus, VZV. They're intracellular, they get inside your cells.
Right.
After chickenpox, VZV doesn't leave, it just goes dormant, hiding in sensory nerve ganglia. Years later, if it reactivates.
Tingles.
Shingles. And because it reactivates in a specific nerve root, the rash erupts along the path served by that nerve. That's the dermatomal distribution. It literally follows the nerve map.
Wow, that's specific.
It is, and that's why rapid treatment is vital. Antivirals, ideally within 72 hours of the rash appearing.
To stop the virus from replicating further down that nerve.
Exactly, and to reduce the risk of post-therapeutic neuralgia, that persistent, nasty nerve pain, which might need things like gabapentin or other pain meds long-term.
Okay, that nerve connection is key. Let's shift gears now from these invaders to Section 3, chronic inflammatory conditions, where the skin's own response causes the problem, starting with a really common one, acne vulgaris.
Ah, acne. It's defined as a chronic inflammatory disease of the pilospacious unit, the hair follicle, and its associated oil gland.
Affects a huge number of adolescents and young adults.
About 80%, yeah. Pathophysiology-wise, you need to think about 4 main things happening.
Okay, what are they?
1, too much sebum production, the oil.
Yeah.
2, the follicle gets clogged, hyperkeratinization. 3, bacteria, specifically P. acnes, colonizes the follicle. And 4, inflammation kicks in as a result.
So those plug pores, whiteheads, blackheads, those are called comedones.
Correct. Those are the non-inflammatory lesions, basically just the first 2 steps. But when you get inflammation involved, step 4, that's when you see the red bumps, pustules, nodules, cysts, mostly face and neck, but also chest, back, shoulder sometimes.
Right. Then there's atopic dermatitis, or eczema. The text describes a shift from an acute to a chronic stage.
Yeah, that progression tells you a lot. The acute stage is typically red, swollen, maybe weepy vesicles, very itchy.
Very itchy, leading to more scratching.
Exactly. And if that itch-scratch cycle keeps going, it can transition to the chronic stage. The hallmark there is lichenification.
Lichenification, what does that look like?
The skin becomes thickened, leathery, the lines might look more prominent. It's the skin trying to protect itself by getting tougher, but it loses its suppleness and normal barrier function.
And there's often a link to other conditions.
There is. It's hard to pin down solely as an IgE-mediated allergy in everyone, but the correlation is strong. About 30% of kids with atopic dermatitis go on to develop asthma, and maybe 35% develop other allergies later, suggests an underlying systemic tendency towards atopicy or allergy.
Before we move on, we should mention the really severe, potentially life-threatening reactions mentioned. Stevens-Johnson syndrome and TEN.
Yes, absolutely crucial to be aware of. These are often triggered by adverse drug reactions. Stevens-Johnson syndrome, or SJS, is also called erythema multiforme major. It involves severe blistering and ulceration, especially of mucous membranes, mouth, eyes, genitals.
Yeah, and TEN.
Toxic epidermal necrolysis, sometimes called Lyell disease, is even more severe.
Yeah.
You get widespread attachment of the epidermis, like a massive burn. These are medical emergencies. They show that skin reactions aren't always just skin deep. They can signal a catastrophic internal event.
A stark reminder.
Yeah.
Okay, we talked about drug reactions. Let's pivot slightly to maybe the most common environmental reaction. Sunburn.
Right, sunburn. The skin's acute inflammatory response to too much UV radiation.
And it's not just redness. It can be worse.
Definitely. Severity varies. Mild is just erythema. Severe can involve blistering, systemic symptoms like fever, chills, headache, and importantly, dark skin burns too. It might look different grayish or even gray-black, but the damage is happening.
So protection is key. Sunscreens, we hear broad spectrum a lot.
Yeah.
What does that actually mean in terms of what's being blocked?
Good question. Sunscreens work in a few ways. Some use chemical absorbers, like PABA derivatives, which soak up UV energy. They're particularly good against UVB, the rays that cause most burning.
Okay.
Others are physical blockers or reflectors, like zinc oxide or titanium dioxide. They create a physical barrier reflecting UV away.
And broad spectrum.
Broad spectrum means it protects against both UVB and UVA rays. UVA penetrates deeper, contributes more to aging, and also skin cancer risk, so you really want protection against both.
Makes sense. All right, moving from UV trauma to thermal trauma. Burns. Classification seems key here, depth and extent. Let's talk depth first. How do you tell a superficial partial thickness burn from a full thickness burn just by looking and assessing?
2 critical signs: pain and capillary refill. A superficial partial thickness burn still has intact nerve endings in the dermis, so it hurts a lot. And when you press on it, the color returns quickly brisk capillary refill. It's often moist and red.
Okay, painful, good refill. What about full thickness?
With a full-thickness burn, the damage goes through all layers, destroying nerves and blood vessels in the area. So counterintuitively, there's often no pain in the center of the burn itself.
No pain. That's unexpected.
It's a bad sign. And capillary refill. There isn't any. The tissue is dead. It looks dry, maybe leathery, waxy, white, or charred. No blanching, no refill.
That lack of pain is a major red flag then. And the extent of the burn, the surface area?
That's measured as TBSA, total body surface area. The common way to estimate this quickly in adults is the rule of nines.
Can you quickly outline that?
Sure. You divide the body into regions that represent roughly 9% or multiples of 9% of the TBSA. Like the head and neck are 9%, each arm is 9%, the front of the trunk is 18%, back of the trunk 18%, each leg 18%, and the perineum is 1%.
Okay, so you add those up, and when the TBSA gets large enough, it becomes a systemic problem.
Absolutely. Large burns trigger a massive inflammatory response and huge fluid shifts out of the blood vessels into the tissues. This can lead to burn shock.
Burn shock meaning not enough fluid in the circulation.
Exactly. It's a type of hypovolemic shock. Causes poor perfusion to vital organs, especially the kidneys, potentially leading to renal failure. It highlights how a skin injury can rapidly become a whole-body crisis.
That issue of poor perfusion connects to another topic,
Okay.
pressure ulcers. Obviously, preventing them involves moving patients, good skin care, but the source also stresses nutrition.
Yes, critically important and sometimes overlooked. Healing demands a lot of metabolic resources. Deficiencies really impair the process.
Are there specific nutrients mentioned?
2 amino acids get specific callouts: arginine and glutamine. Arginine is needed for the immune response in the wound, and it's a building block for collagen.
And glutamine.
Glutamine is basically fuel for the fibroblasts. Those are the cells that actually build the new tissue. Without enough arginine and glutamine, healing stalls.
Good clinical takeaway there.
Okay.
So last section. Section 5, cancers, moles, and age-related changes. We all have moles, or nevi. What's the most important thing to know about them?
Nevi are benign growths of melanocytes. There are different types based on where the cells are junctional, compound, dermal, but the absolute key clinical point for any pigmented lesion is watching for change.
Change meaning cancer risk.
Potentially, yes, especially for malignant melanoma. That's the aggressive metastatic one. The most important warning sign is a mole changing in size, shape, or color. The ABCDE criteria help assess this risk: asymmetry, border irregularity, color variation, diameter 6 mm, evolving.
And the most common skin cancer isn't melanoma, right? It's basal cell carcinoma, BCC.
Correct. BCC is the most frequent type. Thankfully, it rarely metastasizes.
What does it typically look like?
The classic type, nodular ulcerative BCC, often starts as a small, pinkish, sort of translucent bump. It grows slowly, might develop a central crust or ulcer, and often has a rolled, shiny, waxy-looking border. Seeing that should definitely trigger an evaluation.
Okay, let's quickly jump back to childhood conditions. Rubeola or measles. What's the classic sign to look for besides the rash?
The rash itself is macular and blotchy, starts on the face and spreads down. But the pathognomonic sign, the real clincher, is Koplik spots.
The Koplik spots.
Yeah. They appear before the main rash, usually inside the mouth on the buccal mucosa. They look like tiny bluish-white specks surrounded by a red halo. If you see those, plus fever and cough, you're thinking measles.
Good identifier. And finally, just normal aging. What happens to skin structure as we get older?
Even without significant sun damage, skin naturally changes. The epidermis and dermis both thin out. There's less subcutaneous fat. Blood flow decreases.
So it becomes more fragile.
Essentially, yes. Keratinocytes shrink. There's less padding. Wound healing slows down. The skin just doesn't resist injury or bounce back as well. This is why older adults are more prone to tearing and bruising.
And we see some common benign growths, too.
Right. Things like skin tags, those soft little fleshy papules, often on the neck or armpits, and seborrheic keratoses, those waxy, brownish, slightly raised lesions that often look like they're just sort of stuck on the skin surface. Very common, usually harmless.
Okay, that covers a lot of ground. From basic descriptions like lesions and rashes, through infections, inflammation, trauma, cancer, and aging.
It really does. We've seen how the skin acts as this visible gauge reflecting infections like cellulitis, systemic crises like burn shock, even nutritional status impacting ulcer healing.
So really understanding these changes, being able to categorize them quickly, it seems fundamental to pathology overall. Which leads to a final thought for you, our listeners. If the skin is this incredibly observable interface, constantly reacting to both the outside world and our internal state, and we know things like stress, nutrition, or shock show up on our skin almost immediately, what subtle messages might our skin be sending us about our internal health right now that maybe we're overlooking? Something to think about.